Hello, my name is Giang Nguyen, student ID 32086582. Today I would like to present the assessment 3 for the subject 5024, Midwifery Partnership. And the topic for the assessments is Midwifery Focus e-resources for health professionals with women who are refugees. So firstly, I would like to explain what are vulnerable groups. So vulnerable women groups are individuals threatened by social, psychological, or physical risk factor during their pregnancies. So these factors can be domestic abuse, substance misuse, migrant or refugee status, young maternal age, or low socio-economic status. Women who were born overseas represent an increased proportion of women giving birth in Australia healthcare system recently. In 2017, about 27% of women giving birth in Australia were born in non-English speaking country, and this number increased about 10% to compare in 2007. In Victoria, this number was about 40% in 2017, which means over 31,000 women of non-English speaking backgrounds giving birth in Victoria every year, and 10% of them in Victoria metropolitan area are refugee background. So what are social determinants that make refugee women turn to more vulnerable? Firstly, is a continued and long-term stressful life events. They have to suffer from a lot of things during their life before they move to Australia. It includes human rights abuse, war and conflict, loss of family members due to war, separations or resettlement, and those which make them turn to vulnerable to mental health issues, including perinatal mental health. Secondly, is related to their poor health literacies, because living in poor conditions for a long time, including the war, refugee camps, and frequent displacements, associated with poor nutrition, poor personal hygiene conditions, limited access to health services, thus make them to a high risk of getting contagious diseases, medical conditions, and maternal complication pregnancy. Next, they also have a low socio-economic resources that include low income, poor education, poor accommodations conditions, and higher unemployment. So that means they have a financial hardship. They also have an isolated and lack of support due to lack of community connections since they move out of their own community. And last but not least, language and cultural differences, which make them very difficult to access health and maternal care services in Australia. So, based on their social determinants, refugee pregnancies women have to face these challenges or barriers when they try to access maternal and midwifery care in Australia. Firstly, as I mentioned, language barrier. Because the different in communications, they're very difficult to understand education information from healthcare worker. They're also difficult to express what they want or participate on decisions making on their plan and management plan. Even though interpreting and interpreters available in Australia, but in some parts of the countries, these services still very limited, and thus affect to language barrier problem of refugee women. The second is about the transport. Some of them unable to drive. Some can use public transport, but very difficult for them due to the fact that they have to take care of the children, and the school times of other children is not convenient for them to go to see the doctor. Or some living far away from specialists or investigation center. Next is about financial difficulty. Even though public maternal health care service in public hospitals is offered free for people who have Medicare, but people still have to pay to access specialist appointments and investigations tests, especially some of tests in maternity care, which do not cover by Medicare. And apart from that, the woman and their partner have to take leave from work to organize the time to attend antenatal appointment, so that affect their income. Next is the time pressures. Because of their refugee backgrounds, the demand of settlements, including looking for the house, working for the job, are always prioritized over accessing maternity and child health services. Apart from that, expectations about timeliness and long waiting time with appointments in public maternal hospitals also makes them avoid to attend the appointment. Lack of knowledge about Australian health and social care systems lets them turn to limited access to the service. 81% Asian and 78% Middle East women were not aware of continuity of care and group of midwifery practice service in the research of Melbourne in 2025. Last but not the other importance is the discriminatory or stigmatizing care experience that makes refugee women not willing to accept maternity service. It is about 12% in Australia, according to the research in 2025 of Melbourne et al. And this number was about 45% higher compared to other countries. Last but not least is the limited cultural and religious awareness in healthcare system in Australia. For example, the lack of female health professionals provide care to Muslim refugee women in the research of Thompson's et al. In 2022. So how these problems impact on refugee women pregnancies and their childbirth outcome. According to Thompson's research in 2021 and Melrose in 2025, compared to native-born women from refugee background have high risk of lack or not equity of antenatal care visits, perinatal mental health issues or complications pregnancy, obstructed labor or birth interventions, emergency cesarean sections, postpartum hemorrhage. Black women are 4 times more likely to die than women, and those with Asian background are twice likely. They also have to pay more money for medical and maternal services due to their problem, and psychological and social impacts of maternal traumatic events can often be experienced intergenerationally. Regarding childbirth outcome, so children from these women have a high risk of getting preterm, small for gestational age, low birth weight, neonatal intensive care admissions, stillbirth, and perinatal mortality. And these conditions can affect the child's development and health across their life course. So, what are midwifery lead or any other primary healthcare services can have to reduce this impact? So firstly, I would like to introduce about the model of group pregnancy care in Melbourne starts since 2014. So this is actually a multidisciplinary team, including at least 2 midwives, a maternal and child health nurse, and an interpreters, and a community bicultural workers. So a midwife will provide antenatal care and education to a group of the women, not individual, but a group of women at the same time, and they are from the same refugee background. And education appointments will run with the support of bicultural worker and interpreter. The midwife also organize forums, online forums for all of the women members in the group to let them share information, share experience together, and develop the social network so they can have each other during their pregnancy. These models have a very good feedback. The research from these models can improve the return birth rate, low birth weight, maternal knowledge, woman satisfaction, social support, and reduce the cost of healthcare provision to refugee women. It also improves the partnership between the local public maternal hospitals and the community maternal child health services and refugees agency. The number two I would like to mention is the Gross Cultural Worker Service in Sydney starts in 2016. So that is a group to support refugee women from pregnancy to the early childhood of their children at the age of 5 years. It's including firstly the cooperating between the continuities of midwifery care and the interpreters, and this service available 24/7 via phone access to refugee women. So they don't need to go to the center, they can access through their phone. Or the service can also offer home visits in the case of the woman's request. They also run a group of antenatal care at community venue with the associates of a social worker and interpreter. So make the woman turn to that increase the accessible care to refugee women so they don't need to go to the big public hospital. They can easily to access maternal health care at their local service and reduce the cost, reduce the language barrier. For the policies and guidelines to support the care of refugee pregnant women, there are a lot of training programs offered to the midwife to update and increase their knowledge about common medical conditions in refugees populations, including any common contagious diseases, chronic nutrition, and medical conditions. They also provide information and sources for trauma-informed care, which is a high demand in this group, and training and time needed for comprehensive teamwork and collaborations between hospital-based and community-based healthcare professional workers. Increase funding to bicultural worker and interpreter services, and a toolkit of sources for the provisions of care to refugee and migrant women to access maternity service from Department of Health in Western Australia. Thank you for listening.